Hi, thanks for taking the time to watch this video. This is a short video about psychosocial in data gathering as part of the CSA exam. Now, there's a lot of stuff out there about psychosocial, when to do it, how to do it, what's the right way to do it. And I've tried to put all that into a short, sharp, punchy video to allow you guys to take your preparation that little bit further with a little bit more clarity so that you can use it to the best of your advantage. Now, I'm Aman Arora. I'm a GP and a TPD based in Birmingham. I've done the exam myself. I know how stressful it is. I want to make sure that you get the most out of these videos and enabling you to take your preparation forward and get that bit as good as you can. So firstly, why do psychosocial? Now, as a GP, obviously we're not just seeing patients and dealing with a single treatment with a single diagnosis and a single symptom. We're looking at things in a multifactorial way, and using your psychosocial questions is a great way to try and find the link between what's going on in the medicine and something out there that we don't know too much about at this point. So either something in this patient's life is impacting on their symptom or diagnosis or condition, or their condition or their symptom or diagnosis is somehow impacting on their life. And it's our job to try and dig out that root, to try and make that link, so that when we manage this symptom, condition or diagnosis, we're using things in this patient's life and we're looking at things in a holistic, more rounded point of view. One of the great ways of making things is a shared management plan, and we'll come on to how to make that happen in a short while. But that's generally why we do it, and that's why we want to get it right, because it's such a huge part of data gathering in this exam, but also as GPs in general. So what kind of things are in our psychosocial type of history then? Well, we all think of the common stuff, don't we? Home life, work life, smoking, alcohol. Those are traditional ones that we all think about in all patients. Now, there's a couple of others that I tend to think about and just run through your mind and bring out if you think it's relevant to this patient. So when you think about home life, think about relationships. When you think about work life, think about finances. When you think about smoking and alcohol, think about, should I ask drugs in this particular case? Think about driving, think about exercise, think about diet. There's lots of things that go on in people's lives that actually we can be using, not only just to get the information, but also to use it to make that plan that we do in the second half a lot more tailored, a lot more specific, and a lot more individualized to that patient sitting in front of you. Now, for example, things like driving, a couple of these things, people think, well, why ask these things? Well, we tend to think about certain things in certain types of presentations. So driving, for example, we may think about in diabetes, driving we may think about in epilepsy, but actually driving is something that people do day in, day out, and most people in this country do drive, and there could be a link between some of their symptoms and what's going on with their driving. So for example, if someone's got chronic tennis elbow, someone's got really bad knee arthritis, you may find that driving is actually really impacted and they can't get to work and they're struggling, and there could be a link there. If you have someone who has obesity or hypertension or diabetes even, and you're doing the usual type of management things, lose weight, exercise, gym, all that kind of stuff, and the patient's sitting there telling you, look doc, I work 12 hours a day, I can't got time to go to the gym, where am I going to do my exercise? Use the fact that they drive to work, for example, to your advantage. Mrs. Smith, you mentioned that you drive to work every day, and you mentioned it's quite a long drive. How about on a couple of days, maybe park a mile away and walk the rest of the way? That way you can get your exercise and you don't have to go to the gym and you can still do your work in your normal way. So you can sometimes make these things work for you, and the idea is that you want to be using some of these things in their life that you've picked up and worked hard for in the first half and tailor it to them in the second half. And again, we'll come on to that in a little while. But it's just a good example there of how psychosocial is not just work life, home life, smoking and alcohol. It's actually all encompassing, and there's a lot more digging that you can do given the right opportunity. One of the key things that you see with psychosocial questions is sometimes they just appear to come out of the blue, randomly. There's no real reason or link as to why this doctor has just asked this question. So you may be doing some red flag questions, for example, and suddenly home life springs into your mind, or smoking alcohol springs into your mind, and before you know, you've asked the question. Mrs. Smith, who's at home with you? Or Mr. Jones, what do you do for a job? Maybe later on in the case, you may just think about alcohol. Mrs. Smith, do you drink? Do you smoke? Now, these are not wrong questions. You need to get this information, but like so many things in this exam, it's not what you ask, it's how you ask it that's key. And often just throwing these questions out of the blue where the patient has no idea where they've come from, the people who are watching you have no idea where they've come from, can look a little bit haphazard and a bit odd. So one thing that's really good is putting a signpost in before you do your psychosocial questions. We're very good at putting signposts in for things like red flags. It's quite natural to us. But for psychosocial, we don't do it very often. Couple of reasons for doing signposts. Number one, you're telling the patient that this is what you're about to do here, so they understand you're about to ask some questions about psychosocial. And secondly, you're giving yourself a heads up. You're letting yourself know, right, this is my time where I've decided I'm going to do my psychosocial questions. I want to try and make sure I get them all done together so it looks a little bit more reasonable. So, for example, Mrs. Smith, we've not met each other before. I'm just going to ask you a few questions about you and your lifestyle. Sometimes they can affect headaches. Mr. Jones, not met you before. I'm just going to ask you a few questions about you and your lifestyle. Sometimes they can affect the bowels. So try and put a signpost in and link it to the symptom that comes. It just helps them to understand why you're doing it. Second thing that you can do is sometimes things like smoking and alcohol can also sound very random. Even if you've done it with a bit of a signpost, they don't quite understand why you asked me about smoking and alcohol for this particular problem. Is it just because it's on the list? Are you doing a health check? I'm not here for that. So you've got to try and link those with the symptom as well if you decide to do it. So for example, that patient with a headache, Mrs. Smith, might seem a couple of odd questions, but sometimes things like smoking and alcohol can influence headache. Can I check if you do any of those? Someone comes in with depression, anxiety, low mood. Don't just say, do you smoke, do you drink? Link it to the problem. Mr. Smith might seem a little bit odd, but sometimes when people feel low or anxious or particularly worried about something, they can turn to things they think may help, things like smoking and alcohol. Can I check if you do any of those? You get a patient coming with chronic knee arthritis, many years, long-term problem. Asking smoking and alcohol can seem very odd if it's just done as a tick box exercise. But Mr. Smith, you've mentioned you've had a lot of pain in your knee for many years now. This might seem a bit of an odd question, but sometimes when people have a lot of pain for a while, they turn to other things other than painkillers that sometimes help. Things like smoking and alcohol. Can I just check if you do any of those things? So if you do decide to do certain questions in psychosocial, firstly put a signpost that you're about to do this, so they understand that it's coming. And secondly, when you do these questions, link it to the symptom or the problem that they come in with, because then it leaves no doubt that you understand as a GP why I need to ask these questions. I'm not just doing it because the book told me or the course told me, or that's what I know I'm supposed to do. Now, one of the most important things about psychosocial is don't just get the information and leave it. So often people do a really good psychosocial history, they'll get lots of pertinent information, they'll get lots of things that actually are really relevant to the case, and it comes to the second half and it's just vanished. It's just gone. We don't bring it back. It's not mentioned again unless the patient brings it back. Now, you turn around and say, well, what was the point? What was the point of asking all of that stuff if we're just going to leave it to the wayside? So, a classic example, you've worked hard in the first half to find out that this guy who's at work is struggling with his back pain, is causing him to miss work, is really struggling, and he doesn't know what to do. And it's a big worry for him. It's a big issue for him. Yeah, when we come around to the second half, what do? A generic back pain management, talk about stretching gels, all that kind of stuff, which is fine. But we haven't mentioned one of the big things that he's actually come to talk to you about, which is work. So you've done the hard work, not got the rewards for it. Another example, you get a new diabetic and you've worked hard in the first half, you've got a lot of information from this lady, and you've worked out that her diet's not great. She's doing a lot of stuff that's probably impacting her diabetes, that's probably making it worse. However, what happens in the second half? We think new diabetes. What do the guidelines say? What are we supposed to talk about? And we mention diet, but it's kind of just in the list of all the other stuff that you talk to everyone about with diabetes. So exercise, weight loss, diet, and all that kind of stuff. But it's just kind of tagged along, and you haven't shown or demonstrated that the information that I got, I'm using to tailor for this patient. So you've got to get used to bringing things back from the first half. So you'd say things like, Mr. Jones, you mentioned earlier that work was a little bit of a struggle, wasn't it? Now, I want to have a chat with you about that, see what we can do. Maybe we can help. Mrs. Smith, you mentioned earlier that your diet's perhaps not the greatest, and I wonder if you know about the links between diet and diabetes. Maybe there's a little bit of a chat we can have there as to what's good, perhaps what's not so good. Mrs. Smith, you mentioned that you're having struggling with your driving earlier. You talked about that earlier on. Implement driving into their daily life to get some exercise in. Mr. Smith, you mentioned that there was some troubles going on at home and there's a few relationship problems with your wife. Now, I'm happy to have a chat and see if I can offer you anything there, if that's something that you'd like to take further. So don't forget to bring these things back, use the things that you've worked hard for in the first half, and make sure that the management plan is not just a generic one, but actually you're using that information continuously that you've got in the first half to make that plan tailored. Make it a shared plan. often we have come all sorts of tactics to make things shared, to give options and that kind of thing. But actually, are we using the stuff that we're actually working hard for in the first half? Sometimes we don't. It's really important to use phrases like, you mentioned this earlier, now you thought about this earlier on, and start bringing them back, because that's how you're using stuff like psychosocial in the second half and making it work as hard as you can for you. So guys, as you can see, psychosocial is not just about asking those same 3 or 4 questions each and every time, each and every case. There's a few more things to think about than that. Firstly, it's about getting the right questions, the relevant questions that you need to choose depending on the patient sitting in front of you. Secondly, it's all about showing you understand why you're asking those questions. Why, as a GP, it's important to get that information out and how you're going to use it later on to help the patient. And thirdly, it's about bringing those things back in the second half to enable you to make that management plan more shared, more options-based, and more tailored to the patient. Hopefully it's been useful. Hopefully you've picked up some key things that you can take forward in your own preparation. If there are any other areas you want me to create videos for in GP training, please drop me a line. Then my email details, my tweet details are down below. Otherwise, if you are taking the exam in the near future, good luck. I'm sure you'll be fine. And hopefully I'll see you guys again soon.